Hello and welcome everyone. Today we'll be discussing about the increasing role of immunotherapy inside the ICUs. Now, in 1891, William Bradley Collie used live and inactivated Streptococcus pyogenes and Serratia to simulate an immune response against bone and soft tissue sarcomas. Now, his work was foundation to what is now called as immunotherapy, earning him the title of the father of immunotherapy. Early findings of tumor regression and remissions were largely forgotten until the mid 20th century when cancer immunomodulation regained attention. Now, discovery of the interferon, that is anti-leukemic effects, in the 20th century reignited the interest of immunotherapy in cancers. Enhanced understanding of the innate immunity and the adaptive immunity systems contributed to the advancements in this field. So, basic immunology, the normal immune function, all nucleated cells display internal protein fragments in their surface, which are the endogenous protein, which is called the major histocompatibility complex MHC class 1 molecules. Now, specialized immune cells display external exogenous proteins such as MHC class 2 molecules. Cytotoxics, the immune cells that destroy the infected or cancerous cells, are activated when the MHC class 1 molecule bind with the T cell receptor on the CD8 plus T cells. Now, CD28 co-stimulatory molecule on the T cell interact with the ligand like CD80 and CD86. Now, immune tolerance. Normally, the immune system prevents cytotoxic T cell activation against healthy cells through central and peripheral immune tolerance mechanisms. This avoids autoimmune damage to the normal tissues. However, cancer and immune invasion, genetic mutations in the cancer allow them to evade the immune surveillance through impaired tumor antigen presentation, making them invisible to the immune cell, production of molecules that suppress the immune response, modify the surrounding environment to hinder the immune activity. So, what is the purpose of immune therapy? It is designed to overcome these adaptive mechanisms and enable the immune system to target and destroy the cancer cells. The type of immunotherapies that we know are oncolytic virus therapies used of viruses to infect and kill the cancer cells. Cancer vaccines simulate the immune cells to recognize the cancer cells. Cytokine therapies, which enhance the immune cell activity against the signaling using signaling proteins. Adaptive cellular therapies like chimeric antigen receptor T cell, that is CAR T cell. It is genetically modified T cells to recognize and attack cancer cells. Immune checkpoint inhibitors, these block pathways that cancer use to evade the immune attack. So, to summarize the adaptive cellular therapies, these are by definition a treatment approach using T cells as live drug to eliminate the cancer. The examples are the CAR T cells, the tumor infiltration lymphocyte therapy, that is TIL therapy, T cell receptor therapies. So, how does the TIL work? The tumor receptor T cell is isolated from the patient's cancer tissue. These cells are expanded in the lab and reinfused in sufficient amount to counteract the tumor's immune suppression. CAR T versus TIL. CAR T is genetically engineered T cell not reliant on naturally occurring tumor infiltrating lymphocyte, while TIL relies on pre-existing tumor reactive lymphocytes within the tumor. Now, the CAR T cell, the overview is that it is modified to recognize cancer antigens without needing the MHC. So, the first FDA approved CAR T cell was in 2017 for relapse ALL. The indications are ALL, B cell lymphomas, multiple myeloma. The success rate here is in cases where it is relapse or refractory B cell malignancy, the survival can be as high as 83% for 1 year. For 24 months, it is progression-free survival in more than 30% of the cases. So the key mechanism by which it works is that it has a main domain, that is the tumor antigen binding domain, the intracellular signaling or the co-stimulatory domain, the CD28 or 41BB. The co-stimulatory domain affects the clonal expansion and the toxicity profiles. Typical target antigens are CD19 and 20, the B cell maturation antigens. The administration step. So, that is a conditioning chemotherapy used to deplete the immune cells before the CAR T cell infusion is started. This improves the effectiveness. Then you have the CAR T infusion with the modified cells are reinfused into the body. Then you bridge chemotherapy, that is, it controls the tumor burden while the CAR T cells are being manufactured. So this is how the thing looks like. This is the CAR T structure. It has an intracellular signaling domain, the co-stimulatory domain, the transmembrane domain, the hinge, and the ligand binding. So this is the CAR T cell. It comes to the neoplastic cell, and this is how it attacks and produces various damages. So if the reaction is over amplified, it can result in complications. We'll come to them in more detailed manner. So the adverse effects are the cytokine release syndrome. In this, you will get fever, lethargy, hypotension, hypoxia, multi-organ failure. It is within 2 to 5 days of infusion. Duration is 1 week. Treatment is tocilizumab and corticosteroids. Immune effector cell associated neurotoxicity, the ICANS. Here you will get headache, confusion, seizures, reduced consciousness. It can occur 5 to 11 days post infusion. Now, the treatment is against steroids and supportive care. Other complications that you can get are tumor lysis, hemophagocytosis, cytopenias, and graft versus host disease. This diagram here basically shows the mechanism of immune checkpoint inhibitor toxicities. So here you can see that there is increased T cell activity against tumor as well as the normal tissue. So the immune checkpoint inhibitors enhance the T cell activation to target the cancer cells. However, this can lead to T cell attacking normal cells as well. The example of this type of problem is thyroid gland may be affected due to similarities in antigens seen in thyroiditis. Regarding pre-existing autoantibodies, these are the autoantibodies of pre-existing. Some people already have autoantibodies, so this ICI can exacerbate these, causing an autoimmune disorder. Next is increased level of inflammatory cytokines. Here, because of increase in the level of cytokines, you can get a cytokine storm. Finally is complement-mediated activation. In this, the anti-CTLA4 antibodies may bind to the CTLA4 expressed in the normal tissue, activating the complement system. This is the inflammation in pituitary gland seen during hormonal imbalance. So the clinical implication is that these toxicities underline the importance of close monitoring during immune checkpoint inhibitors. Early recognition and management of steroids and immunosuppressive cells and use of multidisciplinary team will be helpful because all of the specialties can be involved over here. So the treatment guidelines is that CRS and ICANS require multidisciplinary management with oncology input. Steroid refractory cases may need additional drugs like cetuximab and anakinra. Prophylactic treatment can be given with antibiotics, antifungals, and antivirals to prevent infections, granulocyte stimulating factors for neutropenia. So the application is CAR T cells offer durable remission in relapse cases, but they have limitations, that is variable patient response, severe toxicities during requiring ICU care, limited data on long-term outcomes and predictive biomarkers. So the clinical pearls is that early recognition of the complications is critical for better outcomes. Always coordinate care with oncology team for CAR T cell specific toxicity. Advanced MRI and immune monitoring help diagnose the neurotoxicity. So these are the two complications, that is the cytokine release syndrome. It is graded into 1, 2, 3, 4. In 1, you can treat with antibiotics, IV maintenance, hydration, and tocilizumab. In 2, you need more further fluid resuscitation, oxygen therapy, tocilizumab, dexamethasone. In 3, anti-immune effector cell, that is grade more than 2. Here you can have vasopressor requirement and you can have to give methylprednisolone as well. In grade 4, tocilizumab as well as methylprednisolone for 3 days. Regarding the neurotoxicity, it is again graded into 1, 2, 3, 4. So in grade 1, there is aspiration precaution and swallowing assessment, low dose lorazepam and haloperidol for the agitation, and dexamethasone. In 2, the similar things, but here you increase the frequency of the dexamethasone or even can consider methylprednisolone. In 3, similarly, you increase the dose of steroids. Finally, with the grade 4, you can consider other therapies like anakinra and other supportive cares. Thank you.